Kia ora. Thank you for joining us on day 8 of the COVID-19 Masterclass. I'm Jackie Haddingham, Manager of the Otago Global Health Institute, OGHI for short. Today's webinar will last for about an hour. We should finish at around 1 p.m. New Zealand time. The webinars are being recorded and will be available on the OGHI website later. We're also live streaming through the OGHI Facebook page. During the webinars, each speaker will present their presentation, and you can ask questions at any time through the Q&A function at the bottom of your screen. After the presentation, I'll read the questions aloud for the speakers to respond. If we're not able to get through all the questions in this session, we'll ask the speakers to provide written responses, which we'll also post on the OGHI website. Today's first speaker, coming to us from Singapore, is Associate Professor Angela Ballantyne. Her academic interests include medical ethics education, research ethics, the ethics of pregnancy and reproductive technologies, and secondary use research with clinical data. She will discuss balancing utility and equity considerations in ICU triage. Angela.
Kia ora koutou. Hi, everybody. So nice to get the opportunity to join you from Singapore. So my day job is at the University of Otago based in Wellington, teaching medical ethics, but I'm in Singapore on an 18-month position as a visiting senior research fellow with the National University of Singapore. So we moved over here in January, which was an interesting time to move a family of 5 internationally. And it's just really nice to have the opportunity to touch base with New Zealand and conversations that are happening there. So let me share this. I think it's just loading. Okay, have you got that, Jackie? Does that look good from your end? Great. So today I want to talk to you about balancing utility and equity considerations in ICU triage, and try and cover this topic reasonably efficiently so that we can have some questions at the end. So a few kind of preliminary comments about ethics. I think medical students, for example, and others often think that doing an ethical analysis will take a complex problem and simplify it. And sadly, and much to their frustration, I think that's not necessarily the case. So in my view, what an ethics analysis can do is take something that's opaque and make it more transparent. But in the process, that sometimes just makes things look more complex. So I give you that warning up front as we get into things today. Everything I'm going to put on the table today sits within what we sometimes call in ethics the grey zone. So there's room for reasonable disagreement about the values and considerations I'm going to put forward. I'm not going to, nothing in the talk today is really an example of sort of egregious ethical wrong. So it's pretty much all on the table, and there's lots of room for reasonable disagreement. And the last comment I'll make is that bioethics or medical ethics is an applied discipline. So that means we need to debate not just the values in abstract, but think about how to apply them or operationalize them in practice. And just as medicine requires good data, bioethics requires good evidence as well. And so that's obviously particularly problematic at the moment in relation to COVID because there's so much uncertainty and so much emerging data regarding prognosis, infection, spread, and so on. So it's a little bit, it's tricky doing medicine, and it's also tricky doing bioethics well in conditions of uncertainty. So quick summary, I'm just going to move my view thing there. Okay, this is essentially what we're going to talk about today, or what I'm going to talk about. I'm going to focus primarily on this tension between triage tools that focus on saving the most lives versus an equity consideration. And I'll define equity in more detail later on, but for now we can think about it as providing people with the resources they need to have a fairer chance at surviving, particularly if they need acute care. One of the problems I think we've seen in the debate about ICU triage so far is that certainly the early debate seemed to treat ICU as a valuable resource that was simply life-saving, and all of the debate was about who was going to get into ICU and who was going to get this life-saving resource. But when we think about how to apply our ethical principles, as I said, they need to be grounded in reality, and the reality with ICU is that ICU is burdensome care. It will often prolong death and suffering. And it's true that the frailer the patient is, the higher the likelihood that ICU will actually do harm rather than benefit. So that complicates the question around triage as well. That means, I think, that if we're thinking about equity in the context of COVID, we need to be thinking more broadly than just ICU. and be thinking about, given we know that the majority of patients that end up in ICU and certainly on mechanical ventilation will actually die, we need to be thinking about quality end-of-life care in the pandemic, and that includes a focus on palliative care, advanced care planning, using scarce resources, PPE for example, to allow visitors for patients at the end of life. So that gives you an overview of the content for today. So to start with, these are the key ethical principles that are invoked in relation to triage conversations. And I'm not talking about New Zealand specifically now, talking based on the literature and conversations I've been involved with here in Singapore, with groups in Germany, groups in the US as well. So I'm going to start with the orange. Overwhelmingly, the primary focus of ICU triage is on saving the most lives. Now, this can be divided into saving the most lives versus more technically saving the most life years. The difference there is how you count. So say you had a patient that survives 3 to 3 months post-discharge, ICU discharge. You have another patient that survives for 12 months and one patient that survives for 5 years. If you're just counting lives saved, all of those 3 patients are counted equally. If you're counting life years saved, then the patient that survives for 5 years counts for more. So technically, a lot of triage documents are focused on saving the most life years, but for simplicity's sake today, I'm just going to refer to that idea as saving the most lives generally. Now, the first pushback we saw was from disability rights groups, who argued that the initial triage documents were discriminatory on the grounds that they might have categorically excluded people with certain disabilities. They might have had age cutoffs. And so we saw legal action in the UK and in the US and different states in the US pushing back against those exclusion criteria in ICU triage documents. That was sort of the first wave of critique. And then the second wave of critique was around equity. And I think it's important to understand the distinction between a triage document that avoids being discriminatory and one that avoids having an inequitable outcome, because the non-discrimination critique is actually a lot easier to deal with than the equity critique. So even triage documents that got rid of terminology or criteria around use of quality adjusted life years on the grounds that those are inherently biased against people with disabilities, and focused instead just on triage according to survivability or prospective benefit. Those triage documents still had to classify patients according to their current and prior health status, and that's largely based on comorbidities. And those comorbidities might include, for example, hypertension, asthma, chronic respiratory disease, diabetes. And what happens is that it can look like an apparently neutral tool on the surface, right? It's treating people similarly. But because those underlying health conditions aren't equally distributed amongst the community, and we know in New Zealand that people who live in poverty, certain ethnic communities, Māori and Pacifica, have higher rates of those comorbidities. If we plug them into that ICU triage tool, we're still going to get inequitable access to ICU between different groups in the community. So the equity critique is much harder to deal with than a non-discrimination critique, and that's because the equity critique and the whole idea of kind of judging survivability are sort of inherently in conflict. So those are the 3 big ethical values that would kind of motivate most triage documents. The next 3 that I'm going to mention are often used as tiebreakers. So that's when you might have 2 patients who come out as kind of ranking equally based on these bigger or more primary ethical concerns, and you might use these to distinguish between those kind of equal patients. So the first is the life stages principle. Now, this attempts to avoid discrimination on the grounds of age, but does say that it would be relevant to consider where in a life course someone is. So you wouldn't distinguish between a patient who's 63 and 65, but you might distinguish between a patient who's 25, 45, or 65 on the grounds that if one of those patients were to die, the younger patient has missed out on a larger proportion of their natural life. So that's the life stages principle. So reciprocity. So reciprocity says that certain people have stepped up in the pandemic and have put themselves on the front line, have taken on extraordinary, heroic risks, often, for example, health workers working without adequate PPE. And they've done that for the benefit of society. So if they were to fall sick as a result of that action, they should get priority access to the resources that they need for treatment. Different value is instrumental value. This might also be used to prioritise access to care, for example, for healthcare workers or other frontline workers, but the logic behind it is quite different from the reciprocity argument. Here, the idea is that some members of the community have instrumental value because of the expertise they have and the role they have, and that there's a priority protecting them so that they can continue to serve the community and or treating them and getting them back in the health system if they fall sick. So those are gives you some idea of the different kind of and complex ethical values that might apply to triage decisions. For today, I'm going to focus on, so I'm just having a little bit of trouble with my screen. There we go. I'm going to focus primarily on comparing the Save the Most Lives approach and the equity approach. So it's fair to say that in the literature, the absolute kind of dominant view is that in a pandemic or an emergency, you need to focus primarily, if not exclusively, just on saving the most lives. So Ezekiel Emanuel is probably the most influential bioethicist in America, and this New England Journal of Medicine paper that came out earlier this year has been very influential. They argue that priority for limited resources should aim both at saving the most lives and at maximising improvements in individuals' post-treatment length of life. The next quote is a philosopher from Germany. As a basic rule, we try to act in such a way that the largest number of people survive. That's because it's in the public interest. And finally, John Wilkinson, who's a philosopher, excellent philosopher in Oxford, who actually visits New Zealand often. So you might have had the chance to see Dom speak yourself. He argues that the ethical balance must shift to emphasising benefit in a pandemic. This will mean prioritising intensive care for patients who have the highest chance of surviving. And this is a graph from John Wilkinson's paper. And you can see here that he acknowledges that fairness considerations or equity considerations are relevant in normal times, but as we get to triage and crisis, the primary focus becomes on benefit, the exclusive focus becomes on benefit. What I think is really interesting about the New Zealand response is that I don't think this characterises a lot of the debate in New Zealand. And I think that's rare from what I have seen. So in New Zealand, I think we're much more comfortable with wanting to keep equity as part of the conversation, even in an emergency context. So the problem with saving the most lives is that by default, you're likely to end up saving white middle class lives. And that's because those people of privilege come into the epidemic with a higher health status. And so when we plug them into a triage tool, they're more likely to score highly on the grounds of survivability. And we've seen this critique very clearly overseas. Both these graphs show data, one from the US and one from the UK, around the disproportionate impact of COVID on people of colour. So, and what both of them do is suggest what you would, the numbers you would expect to see based on share of population. So we can see over here that, for example, in Louisiana, African Americans account for 32% of the population, but they've accounted for 70% of deaths relating from COVID. Similar data we're seeing in the UK, that people of colour are having disproportionately high death rates relative to white people. So that's a problem, obviously. What I want to say is at the heart of this tension between saving the most lives and equity is whether we just want to focus on how many lives we save, or we also want to focus on whose lives get saved. Because if you have a limited set of resources and you're focused on using those to save lives, the priority is going to be saving the lives of the easy lives. So in a very kind of, hypothetical example, you might say you could use those resources to save 100 lives, but they might end up being predominantly white middle class. Or you could save 80 lives by investing some of those resources in people who have need more resources to get the same health outcome, but you might end up saving a much more diverse group of people. So equity, as defined by the World Health Organization, is the absence of avoidable, unfair, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. And I think this is really important because often people will kind of acknowledge equity, but won't necessarily be prepared to take, to carry the burden that equity would require. And that might mean saving fewer lives overall. So that gives you an idea of the tension between saving the most lives versus equity. And then we move on to, if we did want to adopt an equity lens, how might we apply that in ICU? So here I just want to make the point that when we're talking about resource allocation, the type of resource really matters. Applying an equity lens to something like PPE is much more straightforward than applying an equity lens to ICU triage. That's because PPE is essentially just a valuable good. Keeps you safe, and it's not pleasant to wear, it's uncomfortable, but it's not harmful. And it gives you freedom of movement, the opportunity to move safely in a wider range of spaces. Vaccines, also, tiny risk, but largely a valuable good. And so when we have debates about how best to allocate vaccines when they become available, that's a different debate to talking about ICU triage. And I think that difference was missed in some of the early bioethics literature about ICU triage. It's important to realize that ICU isn't just life-saving, but in fact is burdensome care and can sometimes prolong death and exacerbate suffering. Now, it's a little bit hard comparing data from different ICUs because those different ICUs are set in different health systems and have different admission criteria. But what we've started to see is that between 50 to 90% of patients with mechanical ventilation for COVID die, right? So we had this framing of ICU as this really valuable, scarce resource and who was going to get it. And the reality, the picture changed around April. Those patients that do survive are likely to require, very intensive rehabilitation. The Society for Physiotherapy in the UK has predicted a tsunami of rehabilitation needs. ICU is associated with muscle atrophy, deconditioning, sleep disorders, severe fatigue, post-traumatic stress syndrome, cognitive deficits, depression, anxiety, loss of employment, difficulty in performing daily activities. So even patients that survive have a really long road to recovery ahead of them. That, I think, means that if we want to apply an equity lens and we are prepared to use some of our resources to focus on equity, in the context of ICU, we can't just be looking at expanding the admission criteria to allow frailer patients into ICU. Because the risk there is that we get to the point where, on the grounds of equity, we're admitting patients to ICU with COVID when it's actually not in their best interests. So to assess whether it's in people's best interests, we need a lot more investment in services around that process. So we need to broaden the scope of what we're talking about. Scaling up investment in palliative care absolutely needs to be part of countries' pandemic response. We need, I think, investment in communication teams to support families and patients with COVID, making decisions about their future care that are in line with their values. I think we can invest money in advanced care planning for patients that we think might be at higher risk. Now, not all of this applies to New Zealand because of the situation New Zealand's in at the moment, but for countries that are where the health systems have been more overwhelmed, I think these are good ways of channeling resources that might have an impact on vulnerable communities, more so than arguing that those vulnerable communities should be admitted to ICU. Visitors is another issue. If many patients with critical COVID are going to die, I think it's worth having the debate about whether allocating scarce PPE to allow visitors at the end of life is a justifiable use of resources. I think, potentially it is. So in summary, the majority of triage documents focus primarily, if not exclusively, on saving the most lives. That hits up right against equity considerations, and it's likely to mean that the lives we saved are the lives of privileged people. Many of us are concerned about equity and are prepared to put our money where our mouths are and investing in equity responses, but how to do that in ICU is actually really complicated. And I'll wrap up there so we've got time for some questions.
Thank you, Angela. I think people are digesting what you've said and thinking about it and cogitating, because we haven't had any questions come through yet.
Okay.
So if you'd like to perhaps share any additional insights while we wait for a few questions to come through, is there anything else you'd like to maybe emphasize again?
So I can give you another example around the clash between, say, utility and equity outside of the COVID situation, which might make that clear as well. So in the early 2000s, I was working at the World Health Organization, and at that point, WHO and the UN had launched a really ambitious initiative to get 3 million people on antiretrovirals by 2005. And this was ambitious in that it was sort of the first move towards really rolling out antiretrovirals in low and middle income settings. But at that point, the estimates were that approximately 6 million people would require immediate access to antiretrovirals. So the question was, how do you pick the 3 million out of the 6 million who are going to get priority access? And one debate there, not so much around ethnicity, was around, do you roll out the resources in urban settings where you're going to get the most bang for your buck because you can more efficiently access a higher number of people? Or do you use some of the resources to set up testing and treatment outreach clinics in rural areas where you would reach more disadvantaged people? And so that balance between, whether you just go with a kind of strict save the most lives or do the most benefit, or whether you use some of your resources to focus on kind of equity and justice, I think, it's another good example of demonstrating that tension, not around ethnicity in this case, but around rural versus urban populations.
Yeah, I remember that well, being in the HIV field myself, and
right,
it came up a lot. So yeah.
The
reason I'm waffling a little bit is because we don't have any questions. We just got two very positive comments for you. Firstly, a really interesting and relevant thank you very much, Nyamihi Nui. And thank you, Angela, as always, excellent and clear. And here is a question. Okay. Isn't there a tension between equity as applied to population groups versus decisions made in relation to individual patients, including at point of triage for ICU entry, which, by the way, should never occur unless it is judged to offer reasonable probability of benefit?
Yeah, so I think that's right. And I think coming back to that point about reasonable probability of benefit is critical. And what's a little bit tricky about the ICU triage debate is that, we're sort of trying to develop guidance without necessarily having a clear idea of what the demand necessarily is. So I think it's clear, say we take an example where systems are clearly overwhelmed and you've got 50 people who you think could have clear probability of benefit. It's in their best interest. You would want to admit all of them, but you only have 10 beds available. And within that 50, you can use a clinical scoring system to rank them. Do you just give the beds to patients 1 to 10? Or do you give the beds to patients 1 to 8, but then you notice that patient 15 and patient 22 rank highly on some equity account that you've acknowledged as relevant up front, and so you give the beds to patients 1 to 8, 15, and then 22. All of those patients still then stand to benefit. You're not sort of dipping down into the patients 60 and 70 where it's more concerning. But because the situation is moving so fluidly, it's hard to write triage tools that kind of make that point. And so, thank you for reiterating that. Is there a difference between equity applied to populations and equity applied to individuals? I think equity works, it's easier to implement at a population level. So when you're looking at allocating resources to populations, so you're looking at investing in doctors to set up a clinic in a high needs area in New Zealand, right? That's more straightforward. When you're judging between individual patients, that does become more difficult. But I don't think there's necessarily no role for it, but it does. It's a much pointier end of the wedge. I think what people who are concerned about missing out on resources would argue, and this is disability rights advocates and so on, that you can talk the talk at a population level, but if you're always making decisions against the interests of marginalized groups at the individual level, that breeds a lot of distrust and concern amongst those communities.
Thank you, Angela. They're coming in thick and fast now.
Oh, good.
How different or similar are these utility equity concerns to ICU admissions outside a pandemic situation?
So I think they're relatively similar. I think we should hold the same values to heart. I think you'll see it's interesting that, John Wilkinson's view is that the equity, there's lots of room for discussion of fairness and equity in normal situations, but not when we get into a kind of crisis triage situation. I would disagree with that, in part because I think the narratives that we form around ICU, I mean, on one level, why we were talking about ICU, right? Like there's so many more other elements of the pandemic and the pandemic response that are going to have a huge impact on people's quality of life, their income, their health long term. We talk about ICU because it's the pointy end of the wedge and it's really evocative in people's minds. And that means that there's public interest in the sorts of values that we say are important at that point and the kinds of narratives we build around that. And that's going to have a legacy of trust or distrust for populations moving forward. So that's why I think that we need to, I don't think we should be throwing equity out or fairness out because we're in a crisis situation. Now, if the crisis was such that, you know, we were looking at community collapse as a whole, and, you know, the survival of only a tiny percentage of us, then I think in those circumstances, maybe we do focus just on survival. But I don't think that's where we are at the moment. Thanks. Great question.
Have you seen any examples of ICU triage tools that overtly include an equity lens?
Great question. No, so there's lots of talk about it, and I've seen this in various different spaces. So colleagues in, actually I won't say where these were. So some people have talked about in some areas with your clinical scoring having bonus points for ethnicity. So for example, if you know that if you just plug in the clinical scores, that's going to mean that you have very few African Americans, do you add on bonus scores for groups that you know are already coming into the pandemic with health inequities, particularly that result from prior systemic injustice? That's one option. One is, do you allocate a certain number of beds for high needs patients? Do you move resources around a community to ensure that there's more resources on hand, you know, at high needs hospitals? So just, you'll know in the US, lots of medical providers, you know, were shipped into New York to help deal with that. Would you also allocate, you know, health resources in that way to communities that were high needs because of, you know, historical injustice? That said, no, there's a lot of talk about equity, but how you actually do it on the day is much harder. Yeah.
Thank you, Angela. I read an article about a person with disability, Michael Hickson, in Texas this week. Are you familiar with the Texas 10-day futility rule? And if so, do you have any comment on it?
I'm not. I know I'm familiar with the article actually. And I think that just really speaks to the distrust and the difficulty of communicating between these two groups, because I'll speak to clinicians who are really worried about futility and not harming patients, you know, and that's a genuine concern. And then I speak to disability groups who will say clinicians always use the term futility as a way of withholding resources from us, right? And we don't buy that one bit, and we want those resources. And that's because of, you know, historical failure to listen to people with disabilities and treat them equitably. And so then taking that kind of baggage into a pandemic, it just makes those conversations really difficult. I'm not familiar with the Texas 10-day futility law, but I'm going to look that up afterwards. That sounds really interesting. Thanks.
Okay. As you may know, case interview and subsequent close contact management in Aotearoa was severely stressed early in our pandemic. How do you think ethical considerations would influence the rationing thereof?
Right, so in terms of early testing and contact tracing, rather than triage. Yeah, I mean, so basically an equity model says you want to distribute the resources in a way that avoids unfair or avoidable or remediable differences between groups. So rather than just looking at where you get the most bang for your buck, you would look at which groups had higher needs and roll resources out that way. I mean, one thing I didn't mention about equity is that there's two different ways of interpreting equity. It might just be that one group has higher needs because of some sort of innate biological or, you know, feature. So for example, if you have children and one's a growing teenager, they're going to want to eat a lot more, and so you probably give them more food. You don't give them equal amounts of food. But then a lot of the high needs don't just kind of arise out of nowhere. They're caused by historical injustice. So then you have an obligation not just to meet the needs of those communities because they're higher needs, but because you're redressing historical injustice towards those groups. And a large part of that requires giving up power and the privilege that we have, and actually listening to those groups that have higher needs around how they think those resources should be allocated and how policy should be rolled out within their communities. So it's power sharing as much as resource sharing.
True. One more question. Did we discuss when to remove someone from ICU, i.e. not at their request?
Yes, wonderful, great. And so there's lots of stuff that I didn't get to talk about, focusing just on the ethical issues, but there's a bunch of other stuff about process. So yes, withdrawing from ICU is just as critical as when we admit people to ICU. Time trials, limited time trials of ICU are really critical. And again, then one way of thinking about equity is that you might extend those time trials for people of disadvantaged groups. You might give them a little bit longer. So you could adjust time trials that way. The other really important aspect of ICU triage is having, the systems that are really overwhelmed, having ICU triage committees that don't involve the clinician making these one-on-one decisions about their patients. And that's for two reasons. One, to ensure consistency and fairness of decision making, and also to relieve clinicians of that burden. Because we're seeing, there's a really legitimate concern about long-term burnout and psychological distress for clinicians that have had to work in overwhelmed health systems in the pandemic. So thank you for bringing that up. It's a really great point.
Thank you. Associate Professor Angela Ballantyne, thank you for joining us from Singapore. A nice early morning for you.
Yeah, thank you so much. It was such a pleasure to speak to you all. Enjoy the rest of your day.
Thanks, Angela.